Thank you very much, Thibaut. Dear colleagues, I would like to present my work over the last 25 years on frontotemporal dementia. I will do it from a clinical viewpoint, but I could not avoid sometimes difficult basic science issues, but I will do that very briefly and try to speak slowly English. Thibaut asked me that. So I will start. This is the Erasmus MC. We have a new building the last years in Rotterdam. And my presentation will go first to say a few words about Alzheimer's disease versus frontotemporal dementia, because that's important also in concern with fluid biomarkers and neuroimaging. Isabelle Bear already explained a lot about genetic forms. I have also some data, but I will go over it quite shortly. But I will discuss it because it's important with respect to the fluid biomarkers. And if we think about fluid biomarkers, the tau and beta amyloid are the most important biomarkers to differentiate Alzheimer's from FTD. And I will discuss them here because if you see a patient with dementia of unknown type and you are in doubt whether it is Alzheimer's or frontotemporal, you certainly will look for tau and beta amyloid. The last years, the neurofilament light protein has come in as a very nice biomarker and also a reliable biomarker. I will go into that in detail. And apart from that, there are new biomarkers. These biomarkers are not as robust as neurofilament light, but they are sometimes genetic specific. And sometimes they help or might help in the future to see the effect of therapeutic interventions. For neuroimaging, it's important to have MRI, but using MRI as a biomarker, we should know the characteristic features in Alzheimer's versus frontotemporal dementia. And finally, I will end with therapeutic interventions and what's going on with that. Just to have an idea, type of dementias, the Alzheimer's with memory orientation. And we also think about Alzheimer's in terms of memory, but I will show you that some Alzheimer's has prominent language problems. And in these cases, we are in doubt whether it is Alzheimer's or frontotemporal dementia. The vascular dementia is distinct and better to differentiate from Alzheimer's and frontotemporal. And in the frontotemporal, we always say that this inhibition is the most prominent feature. But what I have learned over the last 25 years is that this inhibition is only a minor symptom. Often there is apathy, there is psychiatry, there is Parkinsonism. So that makes also the distinction with Lewy body important, because Lewy body is characterized by cognitive impairment, visual spatial dysfunctions, and hallucinations, and often with fluctuations. But what they all have in common, the dementia, is loss of neurons, and on clinical level, the cognitive dysfunction interfere with daily life. And each type has specific complaints and MRI changes. This is known, the Alzheimer, described by Alois Alzheimer's, the atrophy of the brain. The tangles are tau positive inclusions in neurons, and the senile plaques, that is the amyloid depositions extracellular. And Braak has already shown that there is an distribution over time of these changes in the brain, starting in the entorhinal cortex, temporal cortex, parietal cortex, frontal, and finally the occipital. And what's important is, just for talking about biomarkers, that in Alzheimer, in CSF, the beta amyloid is reduced, and that the total tau is increased, and also phospho-tau is increased. So that helps you, if you have a patient with dementia, to see whether, and if there is memory, but also language problems, whether there is an underlying Alzheimer pathology or a frontotemporal dementia. PET scan is also important. And you would say, well, I know, but it could be sometimes difficult, because then in cases with dementia and with an MRI that is or normal or show generalized atrophy, and you would say generalized atrophy is also always fitting to Alzheimer, but that's not true. Generalized atrophy can also be found in frontotemporal dementia. And then in these cases, a PET scan, a glucose and metabolism distribution pattern, can help you to differentiate between frontotemporal dementia and Alzheimer. What's also important is the so-called microbleeds, the black holes in on the MRI you can see in, I think it's the DIU sequences. So the microbleeds is always accompanying, is also in combination seen with Alzheimer's disease. Pick's disease, frontotemporal dementia. In the past, it was Pick's disease. Mid-90s, the frontotemporal dementia came in. And what's in fact the case is that Pick's disease is now confined to frontotemporal dementia with tau pathology. So in fact, you can only speak about Pick's disease if you have pathology. Frontotemporal dementia is the clinical diagnosis. It's a rare dementia. 10 to 15 per 100,000 people develop frontotemporal dementia. The behavioral changes, loss of initiative, is very prominent. Apathy, coming to nothing, doing nothing. It is often for the caregivers very burdensome if the patient is doing nothing in home or outside home. This inhibition, we know all kind of financial, sexual. This inhibition behavior is very often illustrative, but is not as common as we think. But sometimes it is obsessive compulsive, extremely obsessive compulsive, walking 10 times a day the same route, or always checking the doors, or making jigsaw puzzles all the day from the morning till late at night. The language deficit always develop. And if you have only behavioral changes over years without language problems, I myself become very careful in establishing the diagnosis frontotemporal, because the language centers are in the frontal lobe, and you expect that at one moment the language will be disturbed also. Emotional bluntness is quite common, but you have to ask for it. Otherwise, the people will not, partners will not mention it always. And the disease insight is lost oftenly. Here is Pick's. Here you see the atrophy in the frontal cortex, and with the normal cortex at the occipital, and here you see brain within the occipital normal cortex and frontal very severe atrophy. What's interesting is that Maurice Ravel has probably has developed a kind of a frontotemporal dementia. He had to reduce speech and word finding difficulties since 1926. He had a clumsy right hand. And if you look to the bolero, if you listen to the bolero, you hear a repetition of only two themes. It reminds you of the obsessive compulsive changes you can see in frontotemporal dementia. And with respect to the clumsiness of the right hand, he wrote a concerto pour main chose. So it also emphasizes the clumsiness of his right hand. And he became totally mutistic. And there was brain surgery at 1937 for looking at the tumor, but they found nothing. And after this surgery, he died. So what I already told you, 10 to 15 per 100,000, but it's a clinical, pathological, and genetically a heterogeneous group. It's an insidious onset, especially in the early days or in the early phase of the disease. It might be very difficult. Some patients has been seen by the psychiatrist or has a relation therapy. It's slowly progressive. And then we have the three types: behavioral, primary progressive, and the frontal temporal with motor neuron disease. And here you see, and it is since the early 90s that we better recognize this disease. And that's partly due to the fact that we have good imaging. In the 70s, without CT or MRI, it was more difficult to establish the diagnosis. Here you see a normal brain. Here you see the frontal atrophy with a normal occipital and parietal atrophy. And here you see even white matter changes, as you can sometimes see in severe frontal temporal dementia. Primary progressive aphasia, we have to mention it shortly because it's important in the differentiation, and also it has a role, or fluid biomarkers has a role in that. Prominent isolated language disorders for the first 2 years, no memory problems, no Parkinsonism. And we have 3 forms. And for the progressive non-fluid aphasia, there is a stuttering speech, agrammatism, and the word comprehension is normal. And often the patient has minimal behavioral changes, and there is atrophy in the frontal insula. But what's important also is that if you have a patient with a non-fluid progressive aphasia, that often or frequently it develops over years in a cortical basal syndrome or into a PSP. And sometimes the distinction with Alzheimer's could be difficult. So here you see the non-fluid neuropsychological testing. In the first part of the disease, in the first phase of the disease, it might be that you get a patient that complained about stuttering and word finding problems, and you didn't find nothing. You say, well, I think it's psychiatric or it is psychosomatic. But if you follow the patients 1, 2, 3, 4 years, then finally you have to admit that the patient was right, because then the language problems become more prominent. But remind that in the early phase, the patient complained more than you can observe in your examinations, even in neuropsychology. The non-fluid progressive aphasia is very slowly progressive over years. And finally, as I told you, the word finding problems, the phonological errors, and the impaired syntaxis comes. And here you see a case with a quite normal MRI. And you see here that in the PET scan, the left temporal is show reduced hypometabolism, and you see that also one slide higher, that it extends a little bit in the parietal or posterior temporal. So in the early phase, it's quite difficult to establish the diagnosis. And then the semantic dementia, I will go into that later in detail. Interesting is the impaired word comprehension and the object and nausea. I always ask the patient, do you know what an elephant is? And after they couldn't know that, after they couldn't say that, I ask, what's the typical feature for an elephant? And then I even mention the name of the typical feature, and they do not know that it's an elephant. It's very progressive, slowly progressive, more than 10 years. And obsessive compulsive behavior is quite prominent. And what's interesting in this disease is that it is always asymmetric atrophy of the anterior temporal cortex. And you can, in fact, predict nearly 100% what the pathology would be. And these are round TDP inclusions in the dentate gyrus, as you can see them here. And I come back to this disease later, because recently we have found somatic mutations in this disease, because semantic dementia is always non-familiar. There is no familial occurrence of this disease. And then the logopenic variant of aphasia in Alzheimer's. And it's sometimes difficult to distinguish it from the non-fluent aphasia and the semantic. Impaired sentence repetition is often present, but there is no agrammatism, and there are phonological errors. But how could you distinguish it from the other two types of PPA? In my view, in my experience, it is that the logopenic variant often goes after a while, is associated with memory problems too. And it has also a faster cognitive decline than the other PPAs. And in this case, here is biomarkers quite essential, because if you are in doubt, you have to do its lumbar puncture and to look to tau and beta amyloid. And you will see also on PET scan, hypometabolism, the temporal parietal junction. But I think the PET scan will not solve the problem completely. You should do lumbar puncture. And even I have a case of, for me, it was a clear-cut semantic dementia, but for sure I did CSF, lumbar puncture, and I found a tau and beta amyloid fitting to Alzheimer's. Just even in semantic dementia, you have to be, you have to make the diagnosis more certain. And here you see the changes between the differences between Alzheimer's and frontal temporal. Alzheimer, parietal, occipital, and in frontal temporal, more mid-frontal hypobathymelism. And here below is a kind of, is a typical PET scan of Lewy body dementia with an isolate, posterior isolate singlet sign. So Isabel has already mentioned you a lot about the genetic FTD. I will go over that more quickly. But it's important to realize that FTD is often sporadic, and only 10 to 30% is familial. And mutations are usually found in families that has affected family members. Mostly the patients already know that they have a familial form because they have seen it in previous generations. But sometimes you can find a mutation in unexpected cases, and in which the family is small, or the typical presentations of there were only atypical presentations in affected relatives. I come back to that later. So just to realize the age of onset can vary. It can be between 50 and 60, but sometimes it can earlier than 40 and even later than 65. And you have mutation-specific clinical presentations. I come back to that. In tau, you can find Parkinsonism and cortical basal, but not ALS. And this was the first family with tau mutations. It was described in 1939 and later in 1959 and then in 1984, hereditary Pick's disease. In 1996, in the Ann Arbor meeting, we could find that it was linked to chromosome 17. Here you see 3 Dutch families. All 3 were linked to chromosome 17. And then a few years later, we identified the tau gene in 2 of the 3 Dutch families. And here and in these 2 families, there were tau positive inclusion. And in the case that there was no tau mutation in the 3rd family, there were also no tau inclusion. So that was pathological, a distinct type of FTD. what I said, there are a lot of mutations described in the tau gene. It might be disinhibition, apathy, obsessive compulsive behavior, but also Parkinsonism and epilepsy. And what's important is that Pick's disease Pick's disease is 3 repeat tau isoforms. I don't know if Isabel was going into detail, but I was not going into detail. But Pick's disease is 3 repeat isoforms. It's a shorter form than in Alzheimer, in which you have 6 different isoforms, both 3 and 4 repeat isoforms. And then we came, it took 8 years to come furthermore to the 3rd family, to found a genetic defect in the 3rd family. It was a very large family. If you look this family, this is for clinician quite important, that you can see here that there are 2 sisters that has an onset at 46 and 45. But the mother was at that moment not demented, and she became demented at 74. So to remind you that the variation in progranulin families is quite large. So if somebody told you, well, there is some Alzheimer in an uncle at 76, then you have to realize that it might still be FTD if there was no confirmation by fluid biomarkers. And what's the difference with tau mutations is that the apathy is the most prominent feature, and it is like Alzheimer. And here you see also an MRI of one of our cases with a very generalized atrophy. So it was not strange. It was not strange that this family was initially described as familial Alzheimer's disease. And you need pathology to see that there are no plaques and tangles, but P62 ubiquitin or TDP positive inclusions in neurons. And here you can see cat eye inclusions, as I will show you in the next few slides. Here you see such a typical cat eye inclusion. And if you found that in one of your families, in one of your cases, even if it's not familial, but you find it, I would say you have to look for mutation in progranulin gene. So different genes in the same chromosomal regions may give different brain pathology, but the same clinical FTD or same apathy, obsessive compulsive inhibition, but there are different genes in the same chromosomal region. Thibaut, so far, are there any questions?
I don't see any questions upcoming. I think it's very clear. Thank you very much for this first overview.
Is it too much detail? You can change if you want that it will be faster or more generalized. Tell me.
You know, as French, we don't fancy English that much. So I think you are going at a very good pace. I can understand you very much, and I think that all the students as well. And yes, it helps us to perfect so far. I don't think that there are any questions coming, but they will come.
Yes, I will go on, and then with the next break you can. Yes.
Of course, thank you.
I saw that Isabel already spoke about the familial FTD with ALS linked to chromosome 9. What's important, I don't know if Isabel mentioned it, but the TDP inclusions, as you see here, is a very prominent feature for the FTD with ALS. And so that's and it's linked to chromosome 9, Isabel told you. Here you see the repeat expansions, Isabel mentioned already. And I would like, from a clinical point, present you 3 cases that were not clear-cut FTD and even not clear-cut C9orf, but I will show you how it can works in the clinic. I saw in 2015 77 18-year-old women. She had word finding problems, the comprehension was impaired, she has hallucinations and delusions, and she had also some stiffness and slow movement. And at neuropsychological examination, in fact, all cognitive functions were impaired. So it was not possible to say this is an Alzheimer profile or an FTD. And if we look to the MRI scan, well, we say, well, there is some atrophy, but not much. It will not help us in the diagnosis. And then we did a PET scan, and what's interesting in the PET scan is that the occipital and parietal cortex has a normal metabolism, but the frontal and temporal was decreased. So we did CSF biomarkers, and the CSF biomarkers were not fitting to Alzheimer's. A few years later, I saw her brother. He was 82. He had memory problems. He had forgetfulness. He had some strange behavior, but not very prominent. And he was emotionally changed, as his wife reported. In the past, he had what they called a post-traumatic stress syndrome with some visual hallucinations. It goes back to the Second World War. He had bad experience during that war. And at neuropsychological testing, the memory was quite good, but social cognition, language, and planning was slightly impaired. And if you look to his MRI scan, you say, well, is some white matter changes. Is this perhaps an early vascular dementia? There is generalized atrophy, so it helps me not a lot in differentiating between FTD and C9, or FTD and Alzheimer. And then 1 year later, the son of the first patient came to me. He was 53. He had initiative loss. At his work, his communication was deteriorated, so he was sent to home. He was fired because they, well, he do not communicate about important things. He was some forgetful. He was not interested, and his wife thought he is depressed. And then at neuropsychological examination, his language was only slightly impaired, and attention and memory also. And again, there was a mild atrophy, but it was too much. I say it here in Dutch, but there was too much atrophy for 53. If he was 82 as his uncle, you would say, oh, that's normal. But for 53, that's quite too much. And I did, based on the occurrence of visual hallucinations, but also about one case in the family with ALS, I performed C9 or screening in the first patients and later in the second and in the third. And all three showed the repeat expansions. So what we have is Alzheimer's disease. We have of an Alzheimer type dementia. We can have ALS, but we can also have primary progressive aphasia. But the visual hallucination is quite common. And here you see again the MRI with some atrophy, not very frontal, not very temporal, but generalized, and the TDP inclusions. And what you can see in one single family is one got ALS, another FTD, and the third one even slowly progressive psychiatric disorder. And I come to back that later. In the last 5 years, we have seen 6 patients with uncommon psychiatric disorders, and that means depression, agitation, bipolar, and in one patient there was autism already since 20 years, and it was strange behavior, but there was no progression, and that progression, that loss of progression, but with a sudden onset of changes after 10, 20 years might remind you, should remind you that it might be C9orf. So the psychiatric symptomatology is quite diverse, from patients work normally at home to patients that are admitted at the psychiatric hospital by the occurrence of akinetic stupor. And in all these patients, the MRI did not help us a lot. There was only septal atrophy, sometimes a little bit more frontal, but not always. And at neuropsychology, there was executive dysfunctions, but that was stable over time. So it's always the question, what helps it? And then there was C9orf repeat expansions. So a wide spectrum, dementia, Parkinsonism, ALS, and psychiatric disorders. And here now I will start with the fluid biomarkers. Here, just even to remind you, the different imaging patterns, these are important to remind you because neuroimaging is also a biomarker. For the progranulin, you have asymmetric atrophy. In the C9, you have more generalized atrophy. And in the MA2, you have more temporal cortex atrophy. And here's the spectrum of FTD from ALS to semantic dementia, to behavioral, to non-fluent, to cortical basal and PSP. It all is included in the spectrum of FTD. And here you see the underlying pathology. The ALS, the semantic dementia is always FTD TDP. And the behavioral and non-fluent is often tau. And then you also have some uncommon, very rare FTD FAS. I will not go into that. If you look then to the genetic, you can say that each form can be genetic and sporadic. And at the ALS side, you have the C9orf and the TAR-DDP and the TBK1. The ALS progranulin will never give ALS, but all these clinical forms can be sporadic. And at the cortical basal and PSP side, you have more tau. So here you see the complete spectrum, but also the neuroimaging. Okay, sporadic variants, distinct genetic forms correlate with pathological subtypes, and from a clinical viewpoint, identify familial occurrence. There is large variation within families. There are distinct clinical features, ALS and C9orf, and recognize the atypical presentations. If there is Alzheimer in the family, it should be Alzheimer confirmed by fluid biomarkers, otherwise you are not sure. And then finally, before I go to fluid biomarkers, I would like to say something about genetic cause of semantic dementia. We have now recently a paper in Brain. Semantic dementia is always non-familial, but it is a very uniform disease, always the same clinical features, the same radiology, the same pathology. And the question was, is this perhaps a genetic factor that is somatic? So here you see a normal autosomal dominant way of disease from the first cells to the brain. They all have the same mutations, but for somatic mutations, you will find only during the brain development, the mutation came in and it's confined to the brain. And we have found 3 TDP mutations as somatic mutations in semantic dementia. So in these cases, there were mutations in the brain, but in the blood of the same patient, there are no mutations. So it develops later during the disease, during the development of the brain. And here you see semantic dementia without somatic mutations. Here is the case with an TDP mutation, and here is an autosomal dominant TAR-DDP mutation. So that's quite interesting. Okay, no questions. Then I go finally to the fluid biomarkers. Thibaut?
There might be something you could do. Can you try to reset your presentation, because we don't see the whole of your slides. The titles are cut. If you yes, like that, and then again.
Back.
And I think it will work. Perhaps, yes, I think it will be better. Yes.
Okay.
Then we have to swap again in display.
Where was it? Swap? Oh yeah, display settings.
Yes.
Like this?
Yes. Well, but
now?
we'll see if it works. But it's no. No. The titles are cut again. But no worries. We can go on like this.
Let's try to. Well, how can I do that? Wait, that's important. Otherwise, what I can do is take the other. Wait, let's do this. And now. No.
Good. It's all right.
It's better?
Yes, much better. Thank you. Thank you very much. I may have a question.
Yes.
Is the fact that there are some somatic mutations that may explain some forms of semantic dementia, would it explain the asymmetry? Or is it much too simple an explanation?
No, there is no simple explanation, but you have to remind that for progranulin mutation, that's also a germline mutation, and a germline mutation that gives also asymmetric atrophy in progranulin. There's all progranulin mutations, these are germline, but they have an asymmetric atrophy. So if you would like to know the explanation for asymmetry in somatic, then I would say, well, give me then also the explanation for asymmetry in the germline mutations. You understand?
Yes, yes.
So, and I don't know why, but it is indeed interesting. Yes? Okay.
Thank you.
Fluid biomarkers, important in clinical practice. Patients would like to know if it is Alzheimer, what will be the speed. If it is a semantic dementia, the patient will be at home 5 years later. If it is an Alzheimer, the patient will be in a nursing home 5 years later. So that is therefore the diagnosis is important, but also for the cholinesterase inhibitors in Alzheimer's. So for the treatment, it might be important. Neurofilament in neurological diseases is commonly increased in several neurological diseases, but not in all. Let's say and neurofilaments is a protein that are in the axons, but also in the synapses. So when there is neuron loss, it might be very reasonable that neurofilament light protein came into the cerebral spinal fluid. But you see that in Parkinson's disease and in Lewy body disease, the neurofilaments are not much increased. In Alzheimer, it is more increased in late Alzheimer. In vascular dementia, it's also increased, but it's most increased in frontotemporal dementia, and then most pronounced in ALS. You might say in ALS, there is a very progressive disease with axon loss, so that's what you expect. And what's so interesting about neurofilament light is that we have found it in the cerebral spinal fluid, but with the newest techniques, we can also use it, we can look in plasma. So if you have a patient with a psychiatric disorder and you are in doubt, is it now a neurological disease or is it purely psychiatric, perhaps neurofilament can help you. So, and what also is important is that in plasma, in plasma you can do longitudinal screenings of sampling so that you can see if there is a therapeutic effect. So here's what has been done by one of my colleagues she compared pure psychiatric disorders with FTD, and she found significant lower levels of neurofilament light in the CSF compared to the frontal temporal dementia. So then the point is, in the genetic forms is when does this protein increase? Is that already 20 years before onset, like Alzheimer, because in Alzheimer, A beta and tau in CSF are already increased years before onset, or is it a sudden onset? Is it a sudden increase just before onset? And here you see a kind of a picture. This is the clinical FTD. This is the area of conversion, and you see that depending on the biomarker you take, by a PET scan or functional connectivity, structural connectivity, gray matter, or neuropsychological, you can see the changes. And you can see already changes in Alzheimer's before onset. And the question is, what about FTD? And we have done an FTD study, and we call it FTD risk in our families with at-risk individuals with a 50% chance to get the disease. So we have symptomatic cases, patients, asymptomatic cases, and some of them are controls and other ones are carriers. And we look to neurofilament in CSF and in serum, and we look to imaging, and we make analysis. And let's show you the first data. First of all, we saw that in a small series of 35 patients and 44 pre-symptomatic, that in the pre-symptomatic, the neurofilament levels were low, and they were higher in the symptomatic one. But there are a few things to say about this. First of all, you can see that in progranulin, there's a much more increase than in C9orf and MA2. What does it mean? That doesn't mean that the disease is more aggressive. Is there an other pathophysiology? Is there more loss of axons? What's the reason? We do not know at this moment. And you see also something else. You see here two pre-symptomatic cases with neurofilament levels that are increased. Are they just before symptoms? Are they symptomatic 6 months later? But you see also a few in controls. And that is for therapeutic trials important to know the explanation. What's the reason for these outliers? So we see the most prominent neurofilament level changes in progranulin, but what we also see, and that I will show you in the next slide, we can see we have a few patients or pre-symptomatic ones we followed, and we take a second CSF sample, and we could see that around conversion from asymptomatic to symptomatic, there was a 3 to 4 times fold increase in neurofilaments. So it seems that neurofilament is a good predictive biomarker of a change into symptomatic stage. That might help, and it is the pharmaceutical company working on progranulin works with this idea to treat patients with a sudden increase in neurofilaments. And what's also important, if you look in the symptomatic group, you can find a correlation with disease severity, but also with progression of the disease, but also with survival. And here you see the blue is the third is the 30% with a relatively low neurofilament. This is with an intermediate neurofilament level, and these orange are the 30% with high neurofilaments. So you see that survival is strongly correlated to the neurofilament level. We have the GENFI. GENFI is a European consortium. The French are also participating. Germany, Spain, Portugal, but also Canada. And we have also in the Netherlands 2 centers. 14 centers, more than 350 at-risk individuals, CSF in serum and in cerebrospinal fluid. And every year we do testing, neuropsychological testing, MRI and blood. And what's important, what information give the converters? Those that are pre-symptomatic during at the beginning of the study and converted to symptomatic. These are the most informative ones. And here you can see that we have looked to the longitudinal neurofilament levels. You can see in controls they are stable low. It's a group of 49 patients, 150 pre-symptomatic carriers and 130 non-carriers, and 9 of them converted. And what you can see is that the neurofilament levels in controls are low, slightly higher in the pre-symptomatic, and then you see the steep rise in neurofilaments in the converters. And this rise occur within 1 or 2 years. And if they are symptomatic, it only increases slightly, but some of them also decrease a little bit. And we don't know how to explain that some of them has a decrease and some of them has an increase. So here you see the neurofilament elevated in symptomatic progranulin C9 and MA2. There is a relation with cognition and brain volume. And here you see the 9 cases, the 9 cases in the converters. And this, sorry, but I have this label of GENFI just at a crucial point of the slide, but here is the conversion. It's at time 0, and -1 and -2 years, you already see some increase in neurofilament levels. So this might be important for therapeutic trials. And here you see that there is a correlation between the change in neurofilament level in the longitudinal versus the age at baseline. That's an important issue. But also that the rate of change in the frontal atrophy is correlates with the change in neurofilament levels. So the neurofilament level is a good indication about the brain pathology, brain process of the disease process in the brain for FTD. So neurofilament level, extremely important, differentiate neurodegenerative disease from psychiatry. It predicts symptom onset. It's prognostic in disease severity and progression, and it might be a surrogate biomarker for effect in therapeutic trials. Any questions?
Yes, I have one. So is the neurofilament light dosage a technical challenge, or is it an easy, reproducible, and reliable technique? And I have another follow-up question.
Yeah.
Is the cutoff operational, clinically speaking, to differentiate psychiatric disorders from FTD? Or is there a huge overlap?
Well, as you could see in the, first of all, the first question, it's a robust and reliable biomarker. The only thing that you need is a CIMOA technique, and that's an expensive technique, but I'm sure that in next years, everyone in Europe, there will be CIMOA technical availabilities, and that clinicians could send their samples for neurofilament determinations. So it's really reliable and robust. And then secondly, with concerning the controls and pre-symptomatic, there is a quite sharp cutoff in which there is, I think, not 100%, but let's say between 90 and 95% differentiation between controls and carriers. And the same is true for a psychiatric disorder and FTLD, but I'm not sure if the studies are already large enough to make absolute certain statements about them. But it is, as you can see from the figure a few slides ago, it's quite distinctive.
Okay.
Yeah.
Some cases have a very long duration of psychiatric symptoms,
yes,
mimicking a bipolar disorder,
yes,
before they become an overt
yes,
FTD, in particular in C9
yes,
or 72 mutations. And
yes.
I was wondering whether in this, I don't know if it's pre-symptomatic, because I don't know if those psychiatric symptoms are already the disease.
Yes.
In this pre-symptomatic phase with already some psychiatric symptoms, how is the
Neurofilaments.
Neurofilaments? Yes.
Yes, it's a very good question, because we have only a few cases of last years. The 5-6 cases that we have now, we have to still determine the neurofilament light, because we have done it in a research setting for the genetics, but not in the clinical settings. But that will be really interesting to see if I expect that they have lower neurofilament levels than, for example, a full-blown ALS. But certainly we have to look for that. Okay.
Thank you very much. I have another one. Is neurofilament light relevant to differentiate different etiologies among neurodegenerative diseases?
Well, yes, you can say for PSP and PD, the neurofilament light is lower. You can also say that for FTLD with TDP pathology, the neurofilament light is higher than in the FTLD with tau pathology. But in both cases, in both comparisons, it is not a full and a complete 100% distinction that you can make. It can help you a little bit, but not. You can say if you have a psychiatric disorder and you think, well, it's psychiatric, and you find a high neurofilament level, I'm sure it's not psychiatric. But the other way around, if you find a clear-cut FTD with a low level, you could not say, oh, then it's psychiatric. So it is not, sensitivity and specificity is not 100%.
Thank you. One last question. It's very hard to measure progression in frontotemporal dementia. Quantifying behavior
Yes,
is not an easy task. So
no.
Would you say that neurofilament light would be the main and perfect diagnostic biomarker in the future?
The neurofilament is also increased in multiple sclerosis, and it decreased in therapeutic interventions in multiple sclerosis. And we are talking, I come back to that later, we are talking with pharmaceutical companies, and they really want to use the neurofilament as a kind of a surrogate biomarker to say, well, our drug is working because the neurofilament light is going down. But what you need then is to have several examples of neurofilament decrease, and following these patients for 1, 2, 3 years, say, well, they really has another disease progression than those who didn't get the drug. So perhaps in the future we can say neurofilament is really a surrogate biomarker.
Thank you very much. Maybe one last. Two last questions. How frequently is it pertinent? Is it useful to measure neurofilament light? Is it on a yearly basis that you would do it once it will come to the clinics, of course?
Yeah, well, we are now in the stage of developing or implementing it in the clinics. But then the question is, why would you use it if you find a high neurofilament level? Would you dare to say to the patients, well, you have a high neurofilament level, I think that the disease will certainly progress fast? well, it's difficult, but I certainly expect that neurofilament will get a place in the clinical settings. But the question is, in which way it will be beneficial for the patient to know it.
Purpose. Okay.
But that's the point.
Is CSF neurofilament light still better than blood neurofilament light, or is it as accurate?
I think that there is a very strong correlation. I think we have a slide on. I have a figure on that. One of my PhD students looked for that. I think it's 87% correlation, so it's quite good. I would for neurofilament light, I would say is that if you don't need CSF, if you do CSF just to do tau and amyloid, put neurofilament light also in CSF. But if you don't require a CSF or will do a lumbar puncture, you can go to plasma.
And I have a few more questions, but I will leave them to the end of your speech. Except for this one, I guess that the neurofilament light is very increased in prion diseases and in autoimmune encephalitis as well.
Well, I expect, as far as I know, my colleague, he is working in paraneoplastic of autoimmune encephalitis. He has not done it yet, but perhaps the studies are there, but I'm not familiar with that. But I expect that with a Creutzfeldt-Jakob, but also with autoimmune encephalitis, I expect it. But let's see what the future gives.
Thank you.
Then neuroinflammation, I will go there over more quickly because it's still it is not for the clinical setting so interesting at this moment, but it's important to realize the neuroinflammation is important, or is a phenomenon that you can see in Parkinson, you can see it in Alzheimer, and you can see it in frontotemporal dementia. And why you can see it? You see microgliosis, you see activated microglia, activated astrocytes, and that's what you see through the microscope. But there are also a lot of genetic studies in FTD that show that genes involved in neuroinflammation has an increased frequency in FTLD. So there is an association. And finally, and I will show you the next slide, is that you see a number of neuroinflammatory markers that are increased in FTD compared to controls, but there is quite more overlap than in neurofilament. So it's not 100%. But there is something going on in FTLD and also in Alzheimer. And that can be YKL40, that's an astrocyte marker, interleukins, and also complement factors. And the complement factors points to a microglia activation. The question now is neuroinflammation just an epiphenomenon, or is it contributing to the neurodegeneration? And if so, is it worthwhile to develop anti-inflammatory therapies? These are important questions. And here you see a figure with 3 neurofilaments and 2 neuroinflammatory markers, and you see around conversion, each of these markers has an increase in levels. So there is a correlation with neurofilaments and neuroinflammation. TREM2, YKL, I go over it. It is here you can see what I mean with there is a quite large overlap. Here we have TREM2, it's expressed in microglia, but you see there is a quite large overlap with controls. And YKL40 is a marker for astrogliosis, and increased in AD and FTD and ALS, and you can see also overlap. Here you see the glial fibrillary acid protein, and that is a protein that is a marker for astrocytosis. And here you see the genetic FTD in this slide, and you see that it's really increased in in the genetic FTD. And if you look then to the type of FTD, you can say again, as in neurofilament, that the GFAP is more increased in symptomatic progranulin than in the other forms of genetic FTD. So the GFAP gives a correlation with age, but also with plasma neurofilament levels, and it is inversely correlated with minimental state and brain volume. And these data come from GenFi. Why is that with progranulin? Because progranulin has the progranulin protein has something to do with inflammation, with wound healing and cell proliferation. And the first question is a neuroinflammatory therapy in especially progranulin worthwhile to examine? Isabel told you already, with the progranulin mutation, you found decreased levels of progranulin protein in the carriers, pre-symptomatic carriers, but also in the symptomatic ones. I come back to that later. And here we have looked, is the progranulin levels over time stable? And what we can see that these are 5 time points, time point 0, 6 hours later, 12 hours later, 24 hours later, 7 days later. And you can see there is a quite stable level of progranulin levels in blood. That's important because then you can see if you have a drug, if you can see if there is an increase. And if there's an increase, you can say, well, that's not normal fluctuation, physiological fluctuation. It's really an increase or fluctuation due to the drug. And here is a drug. I came back to that later. So therapeutic intervention are targeting an increase of progranulin levels. That's the issue. If we can increase the progranulin levels, would that be a delay or even prevent frontotemporal dementia? Well, I will go on that quite shortly. It's perhaps too difficult, but what we have done, we have CSFs from pre-symptomatic cases and symptomatic cases. And we were interested if we could find proteins in the symptomatic ones that were not present in the pre-symptomatic ones or the other way around. And therefore we did a so-called mass spectrometry. It's a protein technique or a technique to identify and quantify proteins in CSF. And then we did a validation after that, and then we did an ELISA. And we found that in the symptomatic cases, there were one, that's the neuronal contraction, that were decreased in the symptomatic compared to the pre-symptomatic and the controls. And what is neurocontraction? Neurocontraction, here you see them. Again, it's not as nice as neurofilaments. You see much overlap, but you see that in the symptomatic stage, there's a decrease, or there are lower levels of neurocontraction too, compared to pre-symptomatic and to controls. And we can even show Emma van den Ende, our PhD student, has shown that there is a correlation between the levels of neurocontraction and the minimental state, with normal levels, a normal minimental state, with low levels and lower minimental state. And she did that in the GenFi cohort. And what's interesting is that we have some longitudinal data of pre-symptomatic cases or even converters. And we looked in 2 samples, CSF samples, to the neurocontraction levels, neurocontraction 2 levels. And what's interesting that you see a typical decrease. I called it not a Manhattan plot, but I called it a Schiphol plot, or you can also call it the Charles de Gaulle plot. The descending of the protein approaching the onset of the disease. And here you see also a correlation with the gray matter volume in the frontal lobe. Well, the poly-GP, Isabel told you already a little bit, low or lower in the pre-symptomatic, higher in the symptomatic. That's important. In It was not a significant difference. She already mentioned that it is by typical translation from the repeat expansion, glycine alanine, glycine proline, glycine arginine, and you get, in the first papers, they found dipeptide inclusions in cerebellum, and what they found was increased levels in the cerebral spinal fluids in carriers of C9orf mutations, repeat expansions, and normal levels in cases without C9orf. So the dipeptides indicates is a biomarker, although there are still a lot of C9orf carriers with really low levels, so it's not as distinctive as you would like. And here is the CSF of the GP levels over time, and you can see that they remain quite stable and that they can occur in ALS, but also in asymptomatic ones, but also in ALS and FTD. So it's not that you can say a GP level is strongly correlated to the clinical phenotype. So what we have to do is in genetic FTD is targeting engagement. We have to increase the progranulin levels. In MA2, we have to stop increased aggregation of hyperphosphorylated tau, and in C9 we have to reduce the toxicity of poly-GPs. Interesting, and that's over the last, it was in this year, that plasma tau levels in plasma are increased in Alzheimer. But so plasma can be used to look to tau. In the past, it was always in CSF. We can now do it in plasma, and it's certainly increased in Alzheimer's more than in FTD. And you can see that in FTD tau, it's slightly higher than in FTD TDP. And what's also interesting is that I come back to that over a few slides. If we look to the PET scan, the PET tau and the tau plasma levels are correlated with each other. This is very, very recent. It's a TDP. It's a TDP assay. It's an RT-QuIC, as you have that for a prion disease, the 43T protein. Here you have an RT-QuIC for DDP protein, and it seems that the FTD with TDP inclusions can be detected by CSF. But let's look to further studies before we make robust conclusions. But it seems that we will find a TDP biomarker in CSF, which we can use for differentiating FTD tau from FTD TDP. Now, neuroimaging. Gray matter, white matter, metabolism, and functional MRI. What we have found first in our pre-symptomatic studies was in pre-symptomatic carriers that they have already the first changes in white matter, and especially in the unconated fasciculus. And in our first study, cross-sectional, we saw that the pre-symptomatic ones perform worse on Stroop, had a reduced white matter signal in the unconated fasciculus, and there was also in the functional MRI some reduced connectivity between anterior cingulate and insula. We did a follow-up study because the longitudinal ones is important. What about what happens in the longitudinal? Because at this moment we did cross-sectionals, but what's important if you look to the longitudinal? And we look especially in our group of 30 controls, 43 pre-symptomatics, we look to those that converted to symptomatic. And if we compare the converters with with the pre-symptomatic that stay pre-symptomatic. And there you can see, wait, I go to this. You can say that you see that 2 years before onset, you can see the first changes. You can see changes in temporal volume. You can see changes in cognitive functions. And here you see the gray matter changes 2 years before onset in the small group of those that converted 2 years later into symptomatic. So at the interval level, it seems that we can detect the first changes just before onset. And here you see the changes in where in the white. Here you see that in the corpus callosum and in the unguent fasciculus. That is 2 years before onset. You see here you can see it, the changes, the lowering of the DTI or the DTI signal from -4 year to -2. You see a decrease, and these are in those cases that are not converted and they remain stable. Amyloid PET, I would not discuss in detail because amyloid is in amyloid PET binding is increased in Alzheimer. It's normal in normal aging. It might be increased because 30% of healthy older people has some amyloid deposition in their brains. So it helps if you are differentiating in dementia, but it will not help you to distinguish and control from an Alzheimer, except if it is very abundant. Now we have tau tracers, and tau tracers are interesting because tau deposition in the brain is correlated better to cognitive decline than amyloid binding in the brain. And the first PET tracers are interesting. They show that in controls there is no tau binding. Here you see it in MCIs. You see some tau binding in the medial temporal, and here you see a full-blown Alzheimer with with a lot of tau binding throughout the entire cortex. So the tau tracer seems to be a promising biomarker, but not always. I will show you. We see some strong correlation also in Alzheimer in the cases with, let's say, the lorgopenic PPA. You see that the tau binding is more in the parietal, temporal parietal, and in the posterior cortical variant, it is more in the occipital, while in the amnestic area Alzheimer, you see it more medial temporal. So it seems that tau correlates quite well with the clinical phenotype in Alzheimer. And here you see that there is a strong correlation between glucose metabolism PET and tau PET. So that's also important. It has a better clinical correlation than the amyloid PET. But you would say, well, if it is bind to tau, then it binds to all tau in all types of tau mutation. But that's not true, because it binds only to tau with 3 and 4 repeats. So the true peak disease with three repeats, the tau tracer do not bind the 3 repeat. So it helps you only in those MAP-tau cases with all 6 isoforms, and that is, for example, the 406, not the 403. So that's the limitation of the tau tracer at this moment. So we still need a tau tracer that binds specific tau, 3 repeat tau. And what's also, and here you can see it, that it should be binding, it is binding to the 3 and 4 repeats. It's in Alzheimer, the 406, and you can see it in the medial temporal cortex. But The problem is that from the beginning with the tau tracer, there were cases with semantic dementia that also showed tau binding in the temporal cortex. But for semantic dementia, you would say, well, it is TDP pathology. Why is there tau binding? So we don't know why. It has to be solved. It's not as much as you can see in an Alzheimer, but there is tau binding, and we don't know why. And it has also been shown in C9, but also much less intense, less intense binding than in Alzheimer. The question is it off-target binding? Is it impaired blood-brain barrier? We have to look. It has to be solved. Finally, we have the microglia PET tracer. The microglia, that is the PK11195. It is a tracer that binds to microglia, and it gives microglia activation, or it gives a binding in FTD brains, but also in Alzheimer's. So the question, if you think about a therapeutic intervention with neuroinflammatory biomarkers, inflammatory drugs, you would need this tracer to see the effect. So far, I have a few slides about therapeutics. Is that okay, Thibault? Just 5 minutes.
Yes, it's perfectly okay.
For the FTLD tau, you have to do something on the tau aggregation. You can try to diminish the expression of the mutant tau protein. Then you need antisense oligonucleotides, or you can try to inhibit the phosphorylation or inhibit the aggregation. Several trials are currently, several trials are currently or have been finished without results or are in preparation. So there are ways to tackle this, but none of them is at this moment successful. And at the therapeutic side of FTLD TDP, you can look to increasing the progranulin transcription. You can try to reduce the degradation of the progranulin protein, or you can try to look to C9 ORF expression to diminish that expression. So these are the therapeutic options, and several pharmaceutical companies are working on that. Listen, here you see, this is a trial. This was our first trial in progranulin. We tried to increase the levels of progranulin with a so-called histone, with each DEC rammer inhibitor. And what you can see here, that with 2 doses of that each DEC inhibitor, there was no change there was no difference between plasma progranulin levels. So this trial was unsuccessful. And now there is another trial that is currently is at this moment running. That is a sortilin antibody trial by Alector. And what they do, they give an antibody that binds to sortilin. And sortilin is a protein, is a receptor that takes progranulin and is a step in the progranulin protein decay, so degradation. So if you can stop the degradation of the sortilin pathway, perhaps you can increase the progranulin levels. And indeed, there appears to be an increase in progranulin levels. But the next question will be, is this increase enough to prevent FTD? And therefore, the pharmaceutical company is very eager to look to neurofilaments, look to clinical outcome measurements, so that will be solved in the future. And for the C9 ORF, there is now the antisense oligonucleotide. And in a very recent paper last month by the group of the Mayo clinics, they have found that if they reduce the deep peptides, they can reduce, in mice, they can reduce the TDP inclusion and also the neurodegeneration. And what they have shown here is that with this antisense oligonucleotide, here the red neurons remain higher than in the black, or in those cases in which there is neurodegeneration. And the same for TDP inclusions. With the antisense oligonucleotide, you see that the plasma levels remain lower, and TDP inclusions also much less in number. So I come to the end of the story. It is 25 years ago we start in dark, we start at night, and here we are at the early morning. And I think that in the future we will have a treatment for 1 or 2 FTD types, and these are all the PhD students that has done all the work. I'm just reporting their work. So I have that honor to do that. Thank you very much.
Thank you very much to you, John. So I'm gonna switch to, yes, the video. I have, thank you very much for your course, and especially for the optimistic ending. We need optimism in 2020. I have a few questions for you. The first one will be from Florence about the trials in FTD patients. Florence tells you that 2 years seems to be a short window for an intervention in presymptomatic FTD patients compared to AD trials. Why is that?
2 years.
Yeah,
I can elaborate a little. It is because you said that the change appeared about 2 years before the onset of the disease.
Yes.
And it seems very short compared to
that's right.
the disease.
Yes, it is not as in Alzheimer's that you can see 10 years before already changes, but especially in progranulin, you see that change only 2 years before, and then you would say there is a kind of an explosive onset of the disease pathophysiology, it looks like. While in C9orf, you can see already atrophy 10 or 20 years before. But in progranulin, you see it's quite short before onset. You see changes in gray and white matter and also in neurofilaments. So that's correct what you observe. So, but I don't know why.
I have another questions about the trials, the therapeutic trials on the genetic forms of FTD. Do you think that some of the drugs and treatments that are tested would benefit someday to the sporadic forms as well?
Yes, well, that's the point, because the genetic forms are quite rare. But if you think about a beneficial treatment for that has an effect on tau aggregation, then I expect that it will help also to have a beneficial effect in the sporadic ones, because it's also the same tau, the hyperphosphorylated tau that is deleterious. And then it's important that if you see an FTD patient in your out-clinic department, that you know by biomarkers, oh, this is certainly an FTD tau or this is an FTD TDP. So, and the same for the FTD TDP. If there is a treatment for, let's say, progranulin, it might be beneficial for the total group, but that's not sure. But yes, that will be, we will see in the future.
I have another question for you about the the semantic dementia cases that fix floor tau CPR. It's very intriguing. Were those cases tested for MAPT mutations?
For APP mutations?
For MAPT, for tau mutations.
For tau mutations. Oh,
Yes.
oh okay.
They can present as atypical semantic
yes.
dementia sometimes.
Yes, yeah. Well, we have done that these studies we have done not ourselves, but it's from the literature. And as far as I know, but we have to check the papers, that they were quite sure that there was no underlying Alzheimer by the tau and beta amyloid biomarkers in CSF. But that's an important issue indeed. That's correct. But they saw, so that has to be solved in the future, yes.
I have a question from a colleague named Anne Le Guen. You know, all the students read your 2017 review before the course.
Yes.
So it's a question related to what has been written in this review.
Yes.
In this review, you write about highly specific hypometabolism in the orbitofrontal cortex in FTD. And Anne Le Guen asks you about the kind of hypometabolism that you would allow in psychiatric patients. Patients with a severe depression or bipolar disorder. There is sometimes a hypometabolism in the frontal regions. How do you deal with that?
Yes. That's certainly the case, and we see that sometimes in clinics, and then the nuclear medicine specialists say, well, it might be also seen in psychiatric disorder. And what I extract from their data is that they say that in psychiatric disorder, it is less hypometabolism. The severity of hypometabolism is less pronounced. So, but again, it is not, there are, as far as I know, no studies in which you say, this is the cutoff score of metabolism that distinguishes between FTLD and psychiatric. So that's indeed a clinical important question.
Another question relating to what you said earlier in the first part of your speech about asymmetry of atrophy and pathology in certain neurodegenerative diseases such as semantic dementia. So about this asymmetry, do you have arguments for a previous neurodevelopmental disorder that would explain this asymmetry?
Yes, that's a good question. And I'm a clinician, as most of you. I have tried to understand that, but I have never read a good explanation that for this asymmetry. So I really don't know. There should be a good reason. It should be not chance. There should be any reason, but perhaps it's something to do indeed with neurodevelopment, in which brain the developmental changes or the developmental neurodevelopment has occurred as first. Perhaps there is in all of us a difference in which hemisphere become more mature, earlier mature than the other one, and in the other way around, neurodegeneration, it goes in the opposite way.
Okay, so the questions are a little bit random, and sorry for that. Another about the tau tracers. Do you believe that there will be such thing as a general tau tracer someday that could be that could bind to any kind of tau aggregate, or or is it a science fiction?
No, well, I think more in specific traces, and I also believe in specific treatments in Alzheimer, in FTD, TDP, FTD tau. So I would not aim for a general tracer, because a general tracer will certainly have some disadvantages. So my guess would be for specific tracers. But we need a tracer for the 3-repeat tau anyhow.
Perhaps the last question. How is the situation in Netherlands, in your memory clinic? When you have a patient with a prodromal neurodegenerative disease, what do you do regarding biomarkers? Do all patients have blood biomarkers? Do all patients have progranulin dosed? Do they all have a measurement of the neurofilament light in blood? Do they all have a lumbar puncture? Tell us about your experience as you are our neighbor from Netherlands.
Yeah, okay. I think that if a patient came to our department, they have a really question. They want to know what's going on. If they come because the doctor sent them and say, no, I have no questions, you don't have to do a lumbar puncture. But if they have the question, what's going on, then we do neuropsychology. We do MRI if the neuropsychology is abnormal. If we have some subjective complaints and the neuropsychology is completely normal, there's no reason to do an MRI or a lumbar puncture. But if the neuropsychology confirms the complaints of the patient, we go for an MRI. And if you go for an MRI, I think you have, certainly if it is a patient younger than 65, not 80, 89, but younger than 70, 65, then you have to do lumbar. We do lumbar puncture to come to a certain diagnosis, Alzheimer, FTD, or something else. And then you have the patients. I would like to emphasize that the patients with subtle cognitive changes confirmed by neuropsychology. I have now had yesterday a new one that I saw in 2012. There were certainly neuropsychological changes. There was not much atrophy. And now after 8 years, he said, well, I'm stable. Is this something, how is it possible? You told me that it was FTD based on the neuropsychology. And now he's still stable. And in retrospect, I would say this was an ideal candidate to look to C9orf. And although the family was only one grandmother that has been dementia at late age, I would say you have to do the genetic study to solve the question or to answer the question of the patient and the family, what's going on? But if the neuropsychology is completely normal, you should stop quite early, because otherwise you're doing research and it has any clinical significance. But if there is neuropsychological changes, you have to go further on.
Those are important ethical questions,
Yeah.
of course. So I don't know if the other panelists that can connect and speak, contrary to our students, have other questions. They are welcome to come on stage. But I don't see other questions from the students. We were 69 to follow your course, John, and
Thank you.
I think that. Florence, did you have something to say?
No, I said I saw up to 75.
Okay. Very nice. It's a pleasure.
And it was I hope, thank you if it was a pleasure for you. It was certainly a pleasure for us. It was very, very nice to follow.
Thank you. Okay, then I say you goodbye.
Thank you very much, John.
Yes.
Thank you very much, John.
Okay, bye-bye.
Next time we'll be in Lille, I hope.
Yes, okay, thank you. Bye.
Thank you very much, bye. Et donc, retour au français. Alors, j'espère que vous nous direz, hein, bien sûr, je vous ferai passer un petit sondage. Vous nous direz ce que vous avez pensé de cette expérience internationale au DIU. Vous avez vu qu'on avait demandé spécifiquement à notre intervenant de parler lentement, simplement. Je pense que les diapositives étaient aussi parfois faciles à suivre, parfois plus difficiles. On va essayer de traduire en utilisant les outils de traduction automatique. Je ne vous promets pas que ça marche, mais sinon le diaporama sera mis à disposition également. Voilà, c'était une première pour le DIU. J'espère que ça vous a plu. On en saura plus donc avec le sondage. Je vous propose de faire la pause déjeuner et de se retrouver à 14h en français cette fois-ci, hein, pour une après-midi en français dédiée au diagnostic clinique incluant